And we're live. Okay, hi everyone. Thanks for joining this Science on Google Plus Hangout on Air about Ebola. Joining us is virologist Professor Vincent Racaniello and epidemiologist Tara Smith. And Tara is the person without the name showing up, just so you know who that is. It's thanks to Google glitches. And my co-host is Zuleka, and I'm Budini, and we're both moderators for Science on Google Plus. So let's just start with the absolute basics. So, Vincent, can you tell us what is Ebola? How dangerous is it? And why is this epidemic worse compared to all the previous epidemics we've had in Africa so far?
So, as most people know, Ebola virus was discovered in the mid-70s near a river called the Ebola River in Democratic Republic of the Congo. And since then, it has been associated with a number of outbreaks of serious disease called hemorrhagic fevers, which are quite lethal. And since then, we've also identified a number of other related viruses. So that original one is called Zaire Ebola virus now, or just Ebola virus. And there are Sudan and Bundibugyo and a few others. These viruses probably originated in bats and other animal species, and they cross over to humans when humans contact these animals, consume them as bushmeat, and that starts a chain of infection. And these have really been limited to Africa, where there is consumption of bushmeat, contact with wild animals, and mostly importantly, there is a combination of factors: poor health care, unstable governments, populations fearing hospitals and governments, and all this conspiring to make the disease far more worse than it is. So anywhere from 50 to 90% of clinically confirmed cases, what we call the case fatality ratio, that's the number you see with the different Ebola strains. So in these rural, challenged settings, the virus is quite lethal. But we know that in laboratory animals it's also lethal as well. So I think this particular outbreak has been problematic. It's the largest one that we've seen so far in terms of numbers. And it's also the first time that there's been such an outbreak in Western Africa. It's a combination of political, social, cultural, and economic issues that haven't happened anywhere else. The borders are quite porous. The ecology of these countries has been destroyed pretty much. So it's not surprising. I think in any other country with better developed healthcare systems, this virus would not be anywhere near as lethal as it is.
I think that what you mentioned there about the lack of infrastructure and really the socioeconomics of what underpins Ebola is, I think, the one thing that people are really struggling with, because the media is really focusing on the fact that, erroneously, that it's passed on. There's lots of red herrings about how it's passed on, but really you're saying it's a combination of these socioeconomic issues.
Well, yes, and that's because this virus is passed by very close contact between two humans, and you have to transfer body fluids. And that happens often during healthcare, that happens within families, and that happens when people are burying their dead. There are certain burial customs that require that the family prepare the body for burial that encourages transmission. And so if you remove all of those, if you have the poor healthcare conditions, the lack of infection control, not even proper gowning techniques, poor training in infection control, if you remove all of that, this infection would be nowhere. I think that this is really it's not so much that the virus is at fault here. The virus just finds itself in a human population, but under most circumstances it stops. And if you look at Uganda, which has steadily improved its healthcare system over the years, the case fatality rate there has been dropping.
Right. So what's the best way to actually curtail this? I mean, Uganda sounds like, the textbook example of how you should do it. Tara, can you tell us a bit about what the best strategies are for curtailing the spread of this virus?
Sure. First, you have to know, where it is. So really, primary is case finding. So you find who is infected, you put them into isolation, ideally in some kind of a hospital ward. If that's not available, if that's not acceptable, then within their own home, but keep the family members out of there. As Vincent mentioned, a lot of the way that this has been spread human to human has been through these families when they become caretakers for the sick people, and when they do perform these funerary rites, that they spread the virus person to person. So really, you need to stop that chain of transmission, and you do that by finding the cases and getting them into a hospital. Some cases, a hospital, if they don't practice good infection control practices, and if they don't have good protective gear for their workers, that can produce secondary spread as well. So after you isolate cases, you need to be sure that the healthcare workers are trained and are protected by good, reliable gear. Things that they don't necessarily have to wash again and reuse that can spread the virus as well. And really, to do this, you have to get good buy-in from local governments. That's really been one of the thing in this outbreak that has caused it to become larger and quoting the World Health Organization and others, out of control, is because, as Vincent mentioned, this is the first time that these countries have seen this disease, and they don't really know how to respond to it, and they don't have plans at a local level. So it's difficult coming in as workers from Doctors Without Borders or Samaritan's Purse, one of the other charities that's there. It's difficult for them to come into a community and say, okay, we're going to enforce these regulations upon you. You have to do this with your family members that are ill. That's when this spreads, because then people do flee because they don't understand. So it's a combination of infection control practices, community education, and political buy-in to really get those local leaders to work with the community members to say, this is what you need to do, this is how we're going to stop this. And that's been really difficult, is to coordinate all three of those factors in this outbreak. It really hasn't happened yet.
One of your recent blog posts actually looked into this, about the history and the buy-in of communities. So you did cover some of the ways that Uganda was able to bring together government, community leaders, and through public education in order to start to control Ebola. So can you just take us through a little bit of what has worked?
Sure. So even before Uganda, so Uganda didn't see outbreaks until the 90s, but in the first ones that were mentioned in what is now the Democratic Republic of Congo, and a concurrent one occurring in what is now South Sudan, workers had to go out and had to scan, hundreds of villages looking for cases, and had to work with those local authorities, local chieftains, anyone who was kind of in a position of authority there, and get them to work with them in order to find these cases, get them treated, stop that spread. So that was done even as early as the 1976 outbreak, and that's really what started to kind of quell that one. But in Uganda, it's even become more sophisticated, again, as they've had experience with multiple outbreaks of Ebola, that they have a high-level biosecurity lab there that they can quickly diagnose any suspicious hemorrhagic fever. So something that they think might be Ebola, they get that to the lab as quick as possible. They notify countries surrounding them. They notify hospitals where this has been identified. They start to put in, kind of a chain of, information to let people know that this is there, so that they can, again, really stop those secondary cases when it's very early in the outbreak. And also, again, communicate with others in the area. And that really is critical, because if you can stop that when it's only, one case or two cases before it gets out of control, that's when, that's really the best thing to do for these. So, and that's what Uganda has really implemented in the last few years, is to work on getting these stopped before they get out of control.
Mm-hmm.
So how hard is it to, there's the obvious PPE measures that you can have. You can wear gowns, you can wear masks, don't lick your fingers after treating a patient type thing. But are there any decontaminating agents? Does Ebola die if you just bleach a surface that a patient has vomited on, for example? Aimed at either of you. I'm just curious, what kills Ebola?
No, it is highly sensitive to an activation, and that's one of the reasons why it doesn't transmit by aerosol because
Okay.
it's dried out very quickly. So in BSL-4 laboratories, they have various cocktails that will inactivate it readily. You can easily decontaminate surfaces and so forth. That's not a problem.
Okay.
What's more of an issue is training people. I mean, you could bring in all the BSL-3 gowns that you want, PAPRs, right? But if
Yeah.
you don't train people how to use them, it's not going to help because, for example, taking them off is crucial because if it's contaminated, you can take it off in the wrong way and you're going to get yourself contaminated. So all that precaution is out the window. So
Yeah.
it's not trivial. It's not a matter of throwing lots of resources. You have to have people going in and
Yeah.
training and all those things that Tara said. That is tough to do. In this particular outbreak, it's not going to happen overnight.
So how unlikely is it that there will be an Ebola outbreak in the US or the UK, for example? Because this is something we see in a lot of the news coverage. Oh my God, they've brought Ebola patients into the US. The world's going to end. How likely is that?
I would say you're more likely to have a car accident or crash in a plane or whatever else we do when we walk out the door of our homes. This is so unlikely that I could say it's almost negligible. As soon as there were a case, let's say it was someone came into the U.S., as soon as that person had symptoms of Ebola-like disease, they would be checked right away. As Tara said, early detection. That person would be placed into an isolation room. Proper infection control would be done. All of that, no problem. But in addition, they would get the right treatment. They would get intravenous fluids continuously, because that's one of the reasons why the fatality is so high. These people lose lots of fluids, and if you don't get an IV drip in there, they're going to die. We take care of that. It would be curtailed. It would never spread to anyone else. So I don't think there should be any worry about an outbreak in the US or the UK. As everyone knows, we already have the virus in the country in BSL-4 laboratories. People work with it. There aren't any problems. I've visited many of these labs. They're incredibly secure. So I think you should just take that out of your mind. And if that is what's fueling the headlines, it's just a waste of time, in my view. What do you think, Tara?
No, I absolutely agree. I've tried to emphasize that there are so many more, even if you're talking about things besides the car crashes, I mean, infectious diseases, influenza, measles, mumps, we've had both of those in my home state of Ohio in the past year. There are things that I worry about way, way more than Ebola, even infectious diseases in the U.S. It's just, negligible, as Vincent said.
So I mean, we've talked a little bit off camera about some of the myths that are running around about Ebola, and one of them is about how it's transmitted, and you've both already discussed how it is transmitted through bodily fluid. So what do we need people to understand in developed nations about how do we get this message across to people that they really don't have to worry about this?
Mm-hmm.
Go ahead, Tara.
Yeah, I don't know how to get the message across besides, what people have been saying. Peter Piot, who was one of the people who first discovered Ebola, has said that he wouldn't be afraid to sit next to somebody who is infected, on the subway. This is just not something that is spread by casual contact, by breathing in, shared air. You really need to have close contact with body fluids. So it's just not something that, a casual encounter is going to spread between people.
But what about the pigs?
Pigs. So, yeah, that has been a source of confusion, I think. That there was a study done about 2 years ago by a Canadian group. So let me just back up one moment. So the reason that they even looked at pigs, because, why would they care about pigs, was that there was a 2008 finding of another strain of Ebola, the Reston Ebola virus, in pigs in the Philippines. So this is a very different strain from the one that we're seeing that's causing this outbreak. It can infect humans, but it does not cause any symptoms in humans. So it seems to be completely benign in humans, but we know that humans have been exposed because some humans do have antibodies. So this was found in pigs in the Philippines in 2008. And so people since then were looking at, the potential of of pigs to spread other types of Ebola virus as well. So they did this experiment with Zaire Ebola virus, where they inoculated pigs with this and looked at spread to non-human primates that did not have any direct contact with them, and did find that pigs were able to spread this virus to the monkeys that they used. But pigs' physiology just seems to be very different than humans, not only for Ebola virus, but for other ones as well, that they just seem to be much more efficient at spreading some of these virus by a respiratory route. And even just looking at pigs infected with Ebola Zaire, they don't have the same symptoms as people. They don't seem to get kind of the hemorrhagic symptoms as much. It actually seems to be more of a respiratory disease. So it's just, again, a completely different clinical picture in pigs. They may be able to spread it by air, but the same group did a study with non-human primates who were infected, looked at them spread within monkeys by the aerosol route, did not see any spread. And that's what we've seen, again, with almost 40 years of experience with clinical epidemiology of Ebola virus during various outbreaks. There have been no confirmed cases of human-to-human transmission via simply an airborne route. So the pigs, I think, are mucking it up and perhaps causing some unnecessary fear, but again, that's just really, it's comparing apples to oranges, and if we're looking at human-to-human transmission, airborne route just is not the way that Ebola is spread.
So,
now,
sorry, go ahead.
what a number of people are saying based on this Reston study is, well, what if Ebola Zaire or any of the others could acquire the ability to spread by aerosols? Very much the same sort of worry that we have with avian H5N1 influenza virus. It does not spread by aerosol between humans. Could it acquire the possibility? And of course, we can't predict whether that will happen or not. But all we can say is it hasn't happened. These viruses have been around for ages. They have had opportunity in Africa, the Ebola viruses, to acquire aerosol transmission. My feeling is it's not in the cards for this virus. However it's transmitted among its natural reservoir, which is possibly bats or other animals, it's probably not by aerosol, and the virus is very well adapted to that route. And so I would guess that if Zaire Ebola virus acquired aerosol transmissibility, it would end up being like Reston. It would probably be attenuated and not cause disease. So I don't think this is really worth worrying about. I think it's worth worrying about how to contain outbreaks and develop vaccines and antivirals, to be honest.
I think
you pretty much covered the what if question I was going to ask. Yes, it's not aerosol transmission yet, but what if it mutates and you get it? Because that's something we get asked a lot in our community. So thank you for covering that. The other what if question is, what if a pig sneezes on a human? Can that work? So just a quick answer. What about pig snot?
I mean, in theory, but I mean, you can come up with so many what-if scenarios, each one more ridiculous than the next, that you could do this all day. And what is the point of doing that? As Vincent said, that's not going to help us contain it right now. It's not going to give us new drugs.
But if a pig sneezed on a human, it would be Reston, right?
Yeah.
And then the human would not get sick. Well,
I have had some questions about feral pigs in Africa. So what if they are infected and spreading that between pigs and humans? Again, I think it's an unlikely scenario. So
I think the aerosol, I'm going to call it a conspiracy theory because there have been many scientists who have already covered this, but I think that is fueling the fear that people have. Like, there's so many questions about, well, why don't we just quarantine Africa? First of all, the logistics of quarantining such a diverse continent, and people are really worried about travel, but the United Nations have come out and said that these measures aren't needed. Are there any other things that you're seeing coming through the media? It's just gotten so much coverage, and there's a lot of information that's incorrect. What are some of the other things that you've seen that you'd like to correct for our viewers now?
Go ahead,
Vincent, you want to? Oh, okay.
Go ahead.
I don't know. I mean, if you have something that's coming to mind, some of the things that I've seen have not necessarily been in the U.S., but there's a lot of information in African countries as well, including, I mean, even as extreme as Ebola doesn't exist, that this is something that has been, released by U.S. scientists or doctors, medics, to, decimate the African population, that doctors are actually killing people rather than trying to help them when people go into hospitals. There's rumors that if you do saltwater baths in Africa, that this will cure Ebola. So I guess the rumors that I've been more interested in are those in Africa itself, because they do have potential to really affect the outbreak there. Here in the U.S., honestly, it's more of an annoyance just because it is not, out here in the U.S. It's a shame to have that information and to waste time on that, and for that to potentially get back to other countries. But for me, the most dangerous myths and misinformation are really the ones that are circulating in Africa as well.
Yeah, I think that I'm not sure it's worth to address these, because the one thing I want to say is scientists don't do conspiracy. We're just, we're pretty much like you out there, and we have normal lives, pretty dreary lives, and we don't do this at any level, even in the government. We're just interested in learning things and making people better. But what I do think is worth talking about a bit, and this is part of the conspiracy, that Ebola was brought into the U.S. by bringing these two healthcare workers into the U.S., which is, of course, absurd, because once in the U.S., as I said before, they're going to be so well contained that the infection would never spread. And, of course, these are American healthcare workers. When we send people overseas, the deal is if you get sick, you come back home and we take care of you. So nobody should be second-guessing this. We have such good infection control and treatment. There's nothing ever to worry about with that. So there are a lot of people who have been questioning this move. I think this is horrible. I really think it's not fair, and any service person who gets injured overseas, they're immediately whisked back to the U.S., and that should apply to all people that are doing this kind of work.
Absolutely, yeah.
You want to talk a little bit about what kind of treatments in the pipeline?
Yeah, one of the things is, what's the secret serum that helped the
top
two
secret.
US.
So that's a little bit. So that's another issue. This serum, it's not secret. It's been published. There are lots of papers out there. One thing that people who are not scientists don't often do is look in the literature. And I understand it's a bit obscure, but there are papers and papers out there about these antibodies. They're simply antibodies that have been raised in mice, and they block infection by the virus. And there's a cocktail of 3 of them. They're actually produced in plants and purified. And there's not a lot of them. They're very hard to make, and it's expensive. And so they had very little to treat these individuals. And many people are saying, well, why don't you treat, all of these countries with these antibodies? And, well, we don't have enough to do that. And Tom Solomon, who I talked with last week, he's an infectious disease physician from Liverpool, he said even if you had unlimited amounts of monoclonal antibody, you just can't walk into Sierra Leone and inject everyone with it. They're just not going to let you do that. So there are great therapies in line. These antibodies are great as soon as we have enough of them, and you could use those to curtail this epidemic if you are allowed to do that. There are vaccines that are being developed. There are a number of really good candidates. None of these have yet been tested sufficiently in people so that we could go right ahead and use them. This was an unusual case where it was decided that they could be used experimentally, but there could have been some serious side effects. Fortunately, there were none. But I think this outbreak is going to push the clinical trialing of these antibodies and these vaccines, which is a good thing, because I think they'd be really useful to have for situations like this. And I just want to say one more thing. All of these vaccines, therapies, antivirals for Ebola have been developed in BSL-4 laboratories. That's how you do the animal challenge tests. And there are a number of people out there in the world who are calling for the U.S. to shut down its BSL-3 and 4 laboratories because they think they're not safe. There have been a couple of incidents at the CDC. Well, to them I say, if you want to save lives in Africa, you have to have those BSL-4 and 3 laboratories. So don't start saying silly things like that, okay? It's really important that we have these laboratories. Okay.
Tara, do you have anything to add to that?
No, I think he covered the high points for that one.
Yeah.
Well, this has been the really, it's been a politicized discussion in the media about Ebola and treatments, and it's really been used to push political agendas, which is a real shame because it's contributing to panic that doesn't need to be there.
Yeah, absolutely. Everybody has their own agenda, one way or the other, and it's in the end, it's about medicine. You know, if you go back to the days of infectious diseases like polio, there was a need for a polio vaccine. People got together, raised money, they developed a vaccine, and it was deployed. None of this politicization. I'm not sure why we have to do that nowadays. I don't know who to blame or what to blame. I mean, I could blame the internet, but I like it so much that I don't want to do that. But I think it's unfortunate that every infectious disease issue has to be politicized that way.
Yeah, it hits on a lot of hot button issues that are circulating elsewhere. I mean, it's been used to hit on immigration. It's been used to hit on vaccination, to hit on pharmaceutical companies. I mean, you name it, and somebody has exploited their political avenue with using the Ebola outbreak. So it just seems to be a perfect storm that everyone can use it to their own advantage.
Yeah. One of the questions we have from people following this event, Jane wants to know, how important are traditional burial practices in the spread of Ebola, and what can be done about that route?
I mean, it seems to be fairly central, especially in some areas that, you know, unfortunately you have one member of a family pass, and you'll have several people that work together to ritually cleanse the body, bury it, and boom, all of those people become infected. So, you know, what can you do? And that's really when it comes to the local buy-in, is that, you know, you can have healthcare workers from, again, you know, Doctors Without Borders and others places come in and say, you can't do this. You need to let us take care of these bodies. But that's, you know, that's difficult for someone when you're completely going against their cultural tradition. So that's where you really need that political buy-in from the local leaders to say, we need to put a halt to this. We're going to, you know, instead let these people take care of these, you know, your deceased family members, trust them that they will treat them with respect. But yeah, besides, you know, getting that cooperation, that's really what needs to be done, as I see it, I guess. Vincent, maybe you have other thoughts, ideas?
I think you're right. It's really hard to tell people they can't go through with their traditional practices. But what I think would really help would be to have a vaccine, right? If you had a vaccine that was licensed, you could then, in the area of an outbreak, you could vaccinate families if they had a person, and then they could go ahead and do their burials. You could perhaps train them in a little better infection control practices, but a vaccine or even an antiviral, I think, would really help to bridge that gap, which I think we have to respect, right?
Sorry, I think we lost a bit of, or from my end, what you said at the end there, Vincent.
I didn't hear the last bit. Sorry.
Really? Are you hearing me now?
Yes, we can hear you fine now. It was just the last few words of your sentence that disappeared.
I was just saying that you have to respect cultural traditions and find ways to bridge them, like by using vaccines or antivirals. If a family member has died, you immunize the family, you give them antivirals, and you allow them to do their burial practices, perhaps with some augmented infection control. But to take it away completely, I think, is going to meet with a lot of resistance, and I'm sure that would work.
And a vaccine would be useful for the healthcare workers from the developed nations who go to these countries as well. I mean, I'm sure the two people who were infected, the U.S. citizens, they were trained in, you know, the best practices, how to wear gowns and things like that, and yet they got infected. So, you know, if there is a vaccine around, it would help.
I am waiting to hear how they got infected, because I'd like to hear their story because you're right. They're supposed to be well trained, but you know, in the field where things are crazy, things get breached, and so you can imagine that happened. But I think a vaccine would be great because this outbreak has been going since February. Plenty of time to immunize lots of people. Every time you see a case, you surround the area with immunization. You know, the so-called ring vaccination, and you really could contain it. So I think the sooner we get these out, you know, there's been a little languishing with the vaccine development because this hasn't been a big issue. But now the size of this outbreak, I think, is really pushing them forward.
I think that's another thing that sometimes people don't understand. I know certainly in the discussion we've had on our community is people are wondering why aren't we doing more? Why isn't the scientific and medical community doing more to help people? But there's logistics of rolling vaccines out, and there's also, as you're both saying, there's a need to cooperate with governments and local leaders. So there's no neglect on anybody's part. It's really about learning how to work with the communities affected.
No, I think there's plenty of vaccine and antiviral development going on. It's not an easy thing to test these, right? Because there's not all that much disease. It's not like you make an influenza vaccine and you can test it every year because there's influenza every year. So how do you test it? You know, an outbreak isn't the best situation to test a vaccine in. People are really focusing on containing the outbreak. So that's been the problem. Same thing with antivirals. You know, how do you test them? So people have been wrestling with this issue, and that's why the progress in part has been slow. And also, as you might imagine, pharmaceutical companies aren't all that anxious to get into this because they want to know how they're going to sell the product. But I do think that governments of developed countries have to step up and purchase this vaccine and distribute it. And that's the only way it's going to go forward.
So we're pretty much up on the half an hour that we got to spend with the two of you. Was there anything else you wanted to add before we say goodbye and wrap this up?
I think for me, I've covered most of the high points.
I just want to make another plug for BSL-3 and BSL-4 labs. We need them, and stop telling us to shut them down. I visited a bunch of them, and they are really safe.
And I will say, while we have attention on infectious diseases, vaccinate for the ones that we can.
Yes, yes, that's very important as well. I guess I'm a bit curious because I wasn't aware that there was such a big push to shut down L3 and 4 labs. Do you know why? Is it just, it's unsafe, we shouldn't have them in the countries?
Well, we could do another 30-minute hangout on that. But basically, the experiments with influenza virus, H5N1 influenza viruses, where they were given the ability to spread by aerosol in ferrets, that has stimulated a group of individuals who are saying these experiments are wrong, they shouldn't be done, because the laboratories can't contain them, and they're going to get out. And what's unfortunate is in the past month, as you probably know, the CDC has had a couple of incidents in their BSL-3 laboratories. Nothing escaped, but it wasn't good practice. And so these individuals are saying, well, this shows that these laboratories are just not safe. But I think that's a short-range, short-sighted view. And having visited a bunch of them, I can tell you that they're very safe. And you do have to take risks in science sometime. Nothing in the world is safe. And if you worried about every risk, you wouldn't go out of your front door. We need to make vaccines and antivirals against dangerous viruses. We need to know how they work. And so this work needs to go forward. And so basically, Budini, that's the essence of it. And there's a lot more to it, of course, but there's quite a debate ongoing in the U.S. about it right now.
Well, thank you both for your time. It's been really great, and we could probably talk to you a lot longer as with our other guests. But so we'll make sure that we tweet out both Tara and Vincent's website addresses and blog addresses, because both of you do really great work. So thank you both for being with us.
Yes, thank you so much for taking time on your Sunday to join us to talk about this.
Okay, thank you for having me. Appreciate it.
My pleasure. Hope to see you again.
Thank you.